research project as well. Okay, so getting us started. This is our agenda for the next 2 hours. I'm going to give you all a quick overview of what we'll be covering during these next 2 hours. And then Dr. McKenzie is going to go into her presentation, and then we're going to have time for a facilitated discussion for the end. And then we're going to end with some next steps. Okay, so in the next 2 hours, we're going to go over the principles of community-based participatory research. We'll go over some learning objectives. We'll take questions. And then we'll go over differences between community-based participatory research and traditional research and ethical considerations. And then we're going to go into part 2 and talk about community-based participatory research in action. And then that's when we'll have our facilitated discussion. So now I'm going to hand it over to Dr. McKenzie. You all will be hearing her for the next hour and 45 minutes. And like I said, be sure to ask questions in the chat box as they come up.
So this is Nana, and just before Dr. McKenzie gets started with us, I want to just make sure everyone sees the agenda in front of you. You can, add a couple of hours for your time zone to see exactly what we're going to be doing, but we want to make sure you know that today's webinar, even though we're presenting information, there's going to be a lot of opportunity for interaction, and we really want to hear from you. We know that you all met with your partners over the last few days. We know that you all participated on the webinar on Saturday, which is awesome. Thank you for doing that. Thanks for taking time out of your weekend to do that. It really means a lot to us that you're so committed to this project. And so we're going to, while there will be a presentation component of this webinar, there will also be a lot of opportunity for dialogue and discussion to really think about what exactly it is we want to learn in the process of doing this research project. And so I want to just take a minute to really thank Dr. Sonia McKenzie for making the time to be here with us and for volunteering her time. Sonia McKenzie is somebody who I've known for a number of years as sort of a mentor, somebody who works in the field, somebody who does amazing HIV prevention research from a sociological perspective, and is really committed to issues around structural inequities and looking at how different kind of systems impact risk and impact access to care, and really bringing a social justice perspective to the HIV epidemic. And she's now a professor at Santa Clara University and is, totally just volunteering her time to help us figure out how to do this project. So this is an example of a really wonderful community academic partner collaboration where we have this an ally who's in academia and who has this amazing knowledge base and is offering to share it with us as a community-based organization. So Sonia is going to be doing this training for us. She's also going to be doing the next training for us next week, helping to lead that, and then serving in an advisory capacity on this project as we think about how it goes over the next few months. So with that, I'll go ahead and turn this over to Sonia. And again, just a reminder that although you're muted, you can press *6 at any time if you have a burning question to let us know, but you can also check in on the chat box, and we do encourage folks to use the chat box until we get to the part where we're asking you for your verbal feedback as well. So again, welcome everyone, and I'm going to turn this over to Sonia.
Great. Thanks, Nana. Hi, everyone. This is Sonia. Please call me Sonia. When you, hopefully we'll get to talk. It really is an honor and a privilege to be here today. Thanks, Nana and Narissa, for asking me to be part of this really exciting project. So I'm going to spend just the first part of today's call just going over some of the main principles of community-based participatory research. But I really do want this to be primarily discussion-based, so I'm going to move us through that content so we can get to really where I think the productive work is going to be at, which is in having a dialogue and really talking about your project together, okay? So moving us ahead here, Narissa gave the overview of today. So let's start with some of the main principles of community-based participatory research and an overview of what this means. In terms of, what I really hope to put out there today for you all to be thinking about as you move forward with this project, I want to go over some of, just again, briefly, the historical roots of CBPR. I'm just going to be using CBPR instead of community-based participatory research because it's just easier. We'll define what CBPR is, the rationale for CBPR, why is it that we even want to be taking this approach in the research that we do around health in particular, and what are the key principles. And then I'll go through a description of how CBPR differs from more traditional research approaches. And we'll talk some about some of the ethical considerations that we need to be thinking about as researchers and community partners. So as Nana mentioned, I'm a researcher and have done a lot of research in HIV prevention. My research is community engaged. Some of my research is kind of more CBPR in what I do. But research itself is a really loaded term, and that's partly why I want to start here. So I want to ask you to take a minute and just think, when you say or hear the word research, just think for a minute about what words come to mind, okay? So, oftentimes when we hear the word research, we think of power. We think of positions of power that people who are researchers are typically in. We think of privilege. We think that's not me. Research isn't for me. It's not by me. It's not for me. It's not about me, right? So it's a sort of distancing that comes up. I want to put forward that we can actually reframe research. We can do research differently. We can do research that really is at its core about building community health and is about promoting social justice and health equity, okay? So I wanted to put forward these two. Oh, the sound is cutting in out. Okay. Should I hold? I can hold the phone. Can you let me know if this is any better? Okay, Narissa's asking you in terms of the sound. Sorry. I'm holding the phone now, so I'll keep talking. So Zora Neale Hurston, who's one of my favorite authors, was also an anthropologist. Okay, better on the sound. Great. And I just love this quote. She says, "Research is formalized curiosity. It is poking and prying with a purpose. It is a seeking that she who wishes may know the cosmic secrets of the world, and they that dwell therein." Okay, poking and prying. This is what we think about when we think about typical traditional medical, biomedical, doctors in lab coats kinds of research, right? We think about history of research abuse that has been so profound in this country and that really affects us to this day and communities to this day. Okay, but I really want to put forward the wisdom of Zora Neale Hurston's words here in thinking about, when you're thinking about yourself as a researcher, research involves curiosity, okay? So just thinking about what that can open up and what you can be doing on behalf of your communities. And it's about seeking and this kind of beauty of like, what are the cosmic secrets of the world, right? So this is the sentiment that I take on as a researcher, okay? So it's very much about really shifting, these paradigms of power and privilege. Every story is unique. Every story is important. This is a local artist. And just keep that in mind as you are moving forward as researchers. We need to be hearing people's stories. Our stories are unique and important, and we need to be thinking as researchers, how do we best actually hear people's stories and what is important for people to be telling, okay? So we'll get to that kind of conversation in the discussion. Oopsies, I keep pressing the arrow. Okay, overview of CBPR. So I want to start by defining what CBPR is, and I'm going to draw on kind of the definition that's typically used by the Kellogg Community Health Scholars Program, defining CBPR as a collaborative approach to research that equitably involves all partners in the research process and recognizes the unique strengths that each brings. Okay, CBPR begins with a research topic of importance to the community and has the aim of combining knowledge and action for social change to improve community health. So key words here are collaborative, equitably, knowledge, and action, okay? So really the intent with CBPR is to transform research from a relationship where researchers act upon communities, okay, to answer a research question to one where researchers are working side by side with community members, okay, as we define the questions and methods and implement the research and also disseminate and analyze the findings. So community members are an instrumental part of the research team, and also academic collaborators become more engaged in the activities of the community. It's a reciprocal process, okay? Are we okay on sound? Okay. One of the most important characteristics of CBPR is that it's for and by community members, okay? So this is something that, traditionally in research has been written out of research, okay? And we'll get more to a conversation about that later. But CBPR is research conducted by and for people who are most directly affected by the issues that we are wanting to find out more about, okay? By the people, for the people. CBPR has its roots in social and political movements of the 40s, actually, and then kind of this re-energization of that in the 60s and 70s. So Kurt Lewin was a psychologist who actually fled the Nazis to come to the United States in 1933. And he put forward this notion of action research. So what was really key there is that the research became a commitment to solving social problems, okay? So this really rejected the idea that researchers had to be removed from communities to remain objective. And then also in the work of Paulo Freire, who was a Brazilian educator in the 70s, who believed that communities need to be the ones both identifying what issues we're facing our communities and also coming up with solutions. Okay, so he really put forward this kind of critical consciousness process of kind of asking questions with community members and having community members really be the ones moving forward ideas for solutions and really challenging systems of oppression and exploitation and powerlessness, in particular of poor communities. So in terms of rationale, why should we even use a community-based participatory research approach in our research? This may be a question that everyone on the call, we all have answers to, but I want to just give you some of the reasons that are the most important from my perspective as a kind of health and sociological person who spans community and being an academic myself. So we know that traditional research has failed in solving health disparities. We know that now in 2015, the kinds of disparities that we are seeing in particular among people living with HIV and AIDS around the country, around the world, are actually becoming more and more, are becoming worse, okay? So for some communities, things have gotten a bit better. These tend to be, rich white men, just to be clear, from my perspective. And for other communities, communities of color, in particular African American and Latino women living with HIV, things have not gotten better, okay? So CBPR is really essential in places where, science has really failed us, okay? And as a scientist, I'm saying that. We also know that, as I mentioned before, histories of abuse on the part of researchers and medicine are still present with us. And our community members are like, we're not going to do this anymore, okay? We're not guinea pigs for your research. And research actually does have to be something that is useful, that is going to be actually making change in terms of the needs of our communities, okay? We know that community involvement actually leads to scientifically sound and better research, okay, in many cases. We know that the findings from community-based participatory research can be applied much more readily to develop better kinds of programs and interventions and policy changes that are targeted specifically and more effectively for communities. And then we also know that the kinds of issues around lack of trust, okay, and when I say issues, I mean that this is an issue that researchers need to be taking the responsibility for. Oftentimes it's framed as, oh, well, people just don't trust researchers. Well, it's like, well, actually, what does research need to be doing differently? How can we do research differently so that actually the relationships are equitable and the findings are even better, okay? How can research be done respectfully? And this means moving more, I would say, towards CBPR approaches. Okay. So developing community-based partnerships that are successful in creating relationships and research initiatives that are locally relevant does take time and patience, okay? So some of the main CBPR researchers currently in the United States have worked to come up with some of the underlying principles of CBPR. CBPR is not a method. People often think it's like, oh, it's like you do quantitative research or qualitative research or CBPR. It is not a method. It's a set of principles, okay? And it's about the relationships around the research itself. So in CBPR, we recognize that community itself is important. Community is a unit of identity. We don't just come into communities and have it take a top-down approach, okay? CBPR must and always does and is about building on strengths and resources within communities, okay? So we really tap into what's there and consider how best to move that forward, okay? Communities aren't just absences or places where, things are not. Actually, communities are sources of incredible strength and power and social change. And we know this, and CBPR works to really harness this. Okay, this is an essential principle of CBPR. In CBPR, we have collaboration. We have equitable involvement of all partners in all phases of the research, okay? So it's not just, community members coming in to help out on a research project. That's not CBPR, okay? CBPR projects need to have engagement equitably among everybody from the very beginning, all phases of the research. The idea is that we are researchers. We're setting out to discover some essential knowledge, things we didn't know before, but for the purpose of action. We don't just then sit back and write a paper and submit it to a journal that no one's ever going to read or care about, but we actually are moving toward action, okay, to changing things that are unjust in our communities. Okay, this is mutually beneficial for everyone, but most importantly for the communities where we need to be, figuring out interventions and policy changes. Okay, second slide of principles here. CBPR is focused on the process. It's not just about the outcome. It's not just, okay, we have to generate, a set of figures or numbers or a paper or da-da-da. We actually pay attention to how we go about doing the work. And that matters, okay? We do what's called co-learning. We are all learning together, okay? So, just because I have a degree in public health research, I am learning from everyone here about what needs to happen. You are all going to generate the questions. You are going to implement the surveys and analyze the data, okay? We are all co-learning. We're learning together. And the idea is that this is, the overused word empowering, but it can be such a powerful, I've seen it, I've been through this. It's a powerful thing. Knowledge is power. We say that it's trite, but it's also true, okay? And we're paying attention to social inequalities. We're not just finding out random information about, something that's not really going to change the world and make it a better place. We really are paying attention to really kind of redressing forms of social injustice. So again, it's process-oriented. And in terms of how we understand health, this is really critical. Health is not just kind of a state of physical health about individuals. It's not just about individual health. We understand that people are part of broader communities and social systems and society. The ecological perspective understands more holistically what health even means, right? Health is much more broadly defined than in a lot of traditional research, where it's just like, if you're in one piece, then you're healthy, I guess, right? And then finally, that CBPR insists on dissemination, getting findings out, okay? The knowledge that we come to understand more through the process of the research, that we disseminate, we get that out there. How can the most people really be benefiting from the research that we're doing? Okay, so those are some of the overall principles. I just want to put out a couple of questions. Before we start on a CBPR research project, we have to be thinking about what's driving the research agenda, okay? Because if it's not, something that is a collective drive to find this out, then we have to be thinking, okay, this is not really CBPR, okay? So what is really driving this? Okay, and I think there's some great answers to that question with regard to this project. But I always ask my, research colleagues, what's driving the work that you're doing? Is it about, you need to get a publication for this, or is it really about wanting to make a difference in the world? And then really reflecting on, do you and your team have the skills that it takes? Okay, so again, researcher in a white coat may not necessarily think that communication skills are top of the list in terms of being able to really be a powerful agent of change through research, but frankly, I think communication can be one of the most important things when we're really paying attention through our CBPR work. Quote unquote cultural competence, right? We really have to really understand where people are at and coming from. We have to listen, okay? So communication, a big part of communication is being able to listen. We can't listen to each other. If you can't listen to someone who you are gathering data, survey data from, and hear what it is that they're saying, you're not going to be able to generate the data, okay, and make change. And then in terms of sharing power and control over decisions, decision making is collective, okay? So that's going to be really imperative. If there's a decision that needs to be made about the direction of this particular project, again, communication. It's imperative that you communicate questions or things that maybe don't feel comfortable or feel right. Bring that up, okay? Making the decisions equitably and together. So I've talked a lot, and I'm going to stop talking at this point, but wanted to pose a couple of questions and hear thoughts that people might have at this point, or questions related to content that I've kind of gone over so far. I know it's been a lot. So just thinking together, what do you think about how this project fits into CBPR principles? This is a CBPR project. So what are the most important parts of that for you? I think would be really important to hear. And then just given what I just went over in terms of the CBPR principles, what do you think are the most important principles for this project in particular? So it's really like making the conversation specific to, okay, well, that's all fine and well around the CBPR thing, but let's talk about us. Let's talk about our research project. So I'm going to just let people respond to that at this point.
And just a reminder that to come off mute, it's *6 if you want to unmute yourself and share your thoughts, and then you can remute yourself to reduce background noise by pressing *6 again. Thanks.
Take a moment to come off. Okay. Little ones are allowed to be on calls too. I have a couple of little ones, and I've had many a conference call where they've been very participatory on the calls. I'm seeing Heather's comment here. Great, I'm seeing a comment. Oh, go ahead. Someone about to say something? I think someone about to say something? I see a comment from Janet. CBPR is great for getting community involved, and just want to say absolutely. That's really the only way to get community involved and do kind of the kind of work and outreach that we want to be doing.
Hi, this is Pat. And I'm real excited about this research. I've been involved in several research projects, and some of them have been good, and some of them have left a bad taste in my mouth. But I know because we're involved with this one, this is going to be the best one ever, and we're going to have the best research data to move us forward in the ways that we need to go, and I am just so happy and thrilled.
That's so great. Would you mind saying what have been the things that have not worked out? It sounds like you've actually been involved in quite a lot of research before.
Okay, well, we had like university come into our area and want to partner with the community-based organization, and they said they were going to do this, and they said they was going to do that, but in reality, all they did was use our name, get the money, and then do what they want to do. And then the people that was actually doing the work, when they got refunded for the next 5 years, they cut them all the way out because they knew that they would question everything that they was doing and make them accountable. And so they didn't allow us to be on the board anymore because we always made them accountable for what they said they was going to do. And half of the things. Hold on.
We're off again. We got knocked off.
And so, wait a minute. So a lot of the things that we thought they were coming in the community to do, and the things that we worked hard to see that it got done, it didn't get done. And we didn't get any report backs. Even when they came and they did study with people, or we recruited people for them, we never saw what that data was or what they did with it. And so that really left a bad taste in my mouth.
Yeah. And I mean, I wish I could say that your experience was unique, but I think it's probably experience that a lot of people have gone through, where, you know, there's some form of, okay, you know, come on board and help us with this project. And then the researcher kind of just is like, okay, moving on. I got the money and I'm going to move on. So thanks for bringing that up. And I do think that this is going to be a different and transformative experience, hopefully, for you.
I have no doubt. I know it will be.
Great. Lauren, I'm seeing a comment from you. I would love to hear if you're in a place where you can talk, maybe to hear this more from you so we can kind of talk about it.
Lauren, if you're talking, we can't hear you. Star 6 to unmute. Go ahead.
I know, it's not great. Okay. I mean, I just want to say, Lauren, hopefully we'll be able to hear this from you directly, but I really love your comment. I agree. I think that having an expansive and nuanced understanding of culture is absolutely critical. Your question, do you think we'll be able to form our research or acknowledge these differences? I think it's going to be imperative to acknowledge these differences. So that's, and I'm so glad you brought that up. And I actually think that that's part of what, it doesn't just happen one time. It's like, I think this is going to be an ongoing part of the conversation. It's a part of the conversation right now as we even talk about what CBPR is, but it's also going to be as we come up with questions. Okay, I see that you're in the library. Hopefully what I'm saying resonates, but any other thoughts you have about it, Lauren, keep typing away. But I just want to say, thank you for that, and let's definitely keep that as a thread throughout all of the conversations as we think about questions.
Yeah, and I just want to, Vicki Lynn, I also wanted to acknowledge your comment about what makes this project really powerful, and I agree with you. I mean, I think that in many ways the work we're doing, just the way we're doing it, this is revolutionary because it's all women living with HIV, defining the questions we want to ask about what's going on in terms of, services, access, healthcare for women with HIV in our areas, which is super powerful and just, I think, picks up really nicely on what we always say at PWN, nothing about us without us. All of problems, issues, solutions should be defined by the communities most impacted. And so I want to just thank you for raising that as well.
Yeah. This is Sonia again, and I really want to acknowledge the importance of that, and Anna, kind of your response. And in some ways, it just seems so simple, right? It just seems like, well, this of course is the way that it should be, right? But it is so, so powerful. And it's what PWN does, I think, so critically and so well, and it's why all of you are here, and it's moving and powerful, so. And I see here, Heather, your comment, because most things cater to the male community, and this way our voices will be heard. Absolutely. Absolutely. Anyone else have anything you want to say if you're in a place where you can talk or write up a comment before we move on to the next part of the call, which really will be also discussion. Yeah, Vicki, I'm seeing your comment here about differences, kind of geographic differences that you will be able to see as researchers, right? I think that's going to be absolutely critical here because things really do vary widely between and even within, even within geographical areas. I'm thinking of, I'm sitting here in the Bay in Oakland. I just came from San Francisco. Things are so different depending on where you're sitting in the Bay. So I think that is going to be a really important thing to think about. And so now kind of as researchers thinking about how can we best ask questions to find out that kind of information. So I just want you to hold that. And then as we move into the conversation about, thinking about the kinds of questions you want to be asking to think about that. Any final comments before we move on to the next part of the conversation?
Hi, this is Heather from San Diego. I'm going to hopefully speak before my kids speak. So I just wanted to say that, I think these principles are extremely important. One, for example, for me, I don't access any of the health insurances and ACA, the Affordable Care Act, and Ryan White, and I don't really access all of those, the services that are provided to women or to men living with HIV because I'm prior military, so all my stuff, is completely paid for by other avenues. But for me, as just a woman living with HIV and working in the field, and understanding that those were issues that needed to be discussed, or that needed to be, the women needed help in that area. That's one of the reasons why I'm doing the work, not so much to help myself, but to help the women that I've heard all these different stories from.
Right. That's great. And so important, and it is also important to think about as researchers. This, you bring, yes, your experience, but you really bring the knowledge and wisdom of so many in your community and in your life. And so that is really important to think about in terms of how do we then bring that to bear on the project, and how we do what we do, and the kind of questions we want to ask and stuff. So. Okay. All right. So I'm going to move us into the next sort of short phase again of me talking, and then we're going to be done with that. Just doing a bit of a comparison here around CBPR and comparing it to more traditional forms of research. So when we think about the stages of research, I just sort of wrote down, okay, these are sort of the eight primary stages of research. Okay, so a researcher will identify a health concern. What is it? The specific health issue that we want to be thinking about. Secondly, design a study. You get funding, right? You got to get the money to do the work from somewhere. Sometimes that's a ton of money for not a whole lot of work. We know that happens all the time. And sometimes that's a teeny bit of funding for a ton of work right, I'm saying that's our situation. That's going to make a really big difference, right? So, and then we move into developing the protocols for the study. How are we actually going to collect data? How are we going to recruit? And if we're, keeping people in a intervention or something, retain people's engagement. What kinds of measurement instruments are we going to be designing, right? Moving into that. Is it a survey? Are we doing qualitative in-depth interviews, focus groups? And then, of course, moving into data collection, implementing an intervention, if that's part of what the project is. And then really moving into data analysis and dissemination. And so often in research projects, these people spend years on number two, like getting funding for something, and then they just like rush through the rest. They're just, it's like, oh, great, well, we got that grant. Okay, rush through the rest without being thoughtful about how all of these key, stages are so essential in terms of, then leading to what it is you're going to be able to do and find out. And then finally, dissemination, right? So people will, funding will run out, and they were doing the work until the end, and then, they don't even get anything out about it, right? In terms of, and when we talk about dissemination, we're talking about not just, again, as I said, papers and, collecting dust in libraries that no one ever goes to, or online somewhere where no one's going to read it. We're talking about actually getting this out to communities where this matters most. Okay. So this slide, now we've gone over, these are the stages of research. Here are the first three of them. And on the bottom here, I have, kind of more traditional areas, forms of research, how they actually engage or you kind of move forward through these stages of research. And then on the top, I kind of put a parallel of CBPR. Okay, so in traditional research, oftentimes people actually will move forward a research project based on a funding opportunity. Money's there. Oh, sure, I'll go for that. That's going to be really good for my career advancement, right? But with CBPR, there's full participation of community members in identifying what are the issues that actually matter the most, right? I mean, you could choose to focus on many different things right now, but where will this research, what do we need to know the most about right now, and where is that going to have the most impact? Okay, this increases kind of engagement in the research process as well. Okay, study design, typically, again, in kind of traditional research design, it's all about scientific rigor and feasibility. Like, feasibility just is a fancy way of saying, can you even do it, right? Scientific rigor typically, traditionally, is just about actually lack of engagement. You're considered, to be, impacting your data if you bring any kind of quote unquote bias to the work that you're doing, right? Whereas with CBPR, community members are involved with every single part, study design and, submitting proposals. Okay, it's really generated, remember, by and for community, by and for the people. The next phase in terms of actually then recruiting people and doing outreach, this is a big issue in again, with more traditional scientific research. There's sort of this big conversation about, quote unquote, hard to reach populations. And, as a researcher, my response to that is it's incumbent on doing the research differently to actually engaging people who need most to be engaged, right? So it's sort of a reframing. That's not an issue that people are, quote unquote, hard to reach. It's actually the responsibility of how we do the research to make sure that we are reaching out to the communities who need it the most. Moving us through, again, designing measurement, kind of the surveys and collecting the data. Again, typically, studies will just kind of take what's been done in a prior study and, stick it into their survey document and, move it forward. And in terms of CBPR, all the surveys, and this is what we're going to move into next, is really, community members, community input is really what designs all of the kind of data collection instruments, okay? What this means is that we see that actually the questions are better, right? People are more receptive to questions. All these researchers all the time will, they'll go into the field with a survey, and then they'll be surprised when people are like, I don't want to answer that question. And it's because they did not, take the right way, I think, of actually designing the questions. And then moving through intervention design and then analyzing and interpreting the data and dissemination. Researchers get a lot of credit when they publish. It's like the better, more prestigious journals they publish in, it's good for their career, right? There's a lot of power and privilege that plays itself out and is replicated through the research process. CBPR challenges that and says dissemination, actually the most important form of dissemination is dissemination that is in communities. Okay. Okay, so as researchers, as we all know, questions related to ethics are at the center of what we need to be thinking about when we're doing our work. So I just wanted to sort of, pull out just a few, and again, more just to kind of open up conversation or discussion if any of these feel particularly relevant or important to consider or to hear your thoughts on them. But some of the core, ethical principles underlying our work as researchers is, respecting human dignity in all people whom we are working with. Free and informed consent, that, people are actually consenting with full knowledge of what the research is for and what will come of the research, all right, so that the consent process is one that people themselves have a full understanding of. Respect for vulnerable people in particular, for privacy and confidentiality, of course. People are not going to be participating in research if there is any potential threat to privacy and confidentiality. Justice, the work that we do at the end of the day is about justice. It's about social justice. It's about challenging forms of oppression that are very systemic and oftentimes hard to tackle, but it doesn't mean to say we shouldn't be doing it. And then also the ideas around and kind of the necessity of maximizing benefits and minimizing harms, right? So participating in research, it can be stressful, it can be hard, it can bring up issues, it can be a trigger for people as they're filling out a survey. So we need to be thinking about that as we are thinking about the kinds of questions we're asking too, and what kinds of questions are appropriate, what might be hard, what forms of support do we want for people, if that feels relevant, okay? In terms of CBPR and kind of ethical considerations, a really key question is who represents and speaks for the quote-unquote community? You know, and I've been using the word and the term the community a lot as I've been talking, you know, and I do so with a lot of kind of in terms of what I hear from you, Lauren, of kind of just understanding of the nuance in that there are many communities even within the quote-unquote community, right? So we need to always be thinking about that and issues of representation, okay? Who's getting to speak here, okay? And CBPR throughout is a process of self-reflection and paying critical attention to the process of research itself and also through implementation. How do power dynamics play themselves out in the implementation, okay? These need to be called out, they need to be named, and they need to be, you know, part of an ongoing dialogue, okay? If we are to consider the work that we're doing as researchers as work that is about and for justice. So now I'm going to stop and ask for any questions. If people have questions, again, that's related to the content or things that you'd like to discuss at this point, please go ahead and post or unmute *6 and raise your questions.
Can you guys hear me?
Yes.
Oh, this is Heather from San Diego. I'm assuming that we will also have a release of authorization and things like that for the people that are going to be taking the surveys or questionnaires to sign.
Yes, there will be informed consent forms for everybody to sign that give them information about, you know, how their data is going to be used. The fact that it'll be confidential, that it won't be shared, all of that will be in the informed consent form. Yeah, and we'll develop those. That'll be a standardized form that we'll send to you all, that you'll have them sign before people participate in the research, and then you'll mail those back to us so that we have them on record. You can also, if you want to, you can keep copies for yourself, but we're going to actually set up a more simple tracking system. We did this last time for the Sexual and Reproductive Health Care Survey. I know Ebony was part of that process, where we had another document where you could just kind of have the participants sign that they had, kind of check off that they had signed the informed consent form, check off that they had gotten the incentive, and then you would have a copy of that as well. So all the paperwork would be maintained with us.
I'm seeing Lauren's question posted. Can you identify the community involvement that's occurred in steps 1 and 2 of our study, and over what time frame will we be attempting to retain participants? So when you're talking about stages 1 and 2, I think you're talking about the identification of what the research study is actually going to be studying, and then getting funding. So I'm going to let Nana talk to that.
Yeah, that's a great question. So, you know, the impetus for the study really emerged from what we had been hearing from you all and from the policy work group, from women who are involved on the regional organizing work group, that there are all these concerns around what's going on in terms of services for women living with HIV, and the changing environment, the changing policy environment, both in terms of the Affordable Care Act, states that are not expanding Medicaid, and what's going on with the ongoing questions around Ryan White and some of the shifts in funding that we're already seeing. And then separately from that, just sort of the overall like political will issue and how that's driving funding, and is driving funding away from women in particular and services for women in particular. And so the impetus for this project really emerged from what we heard from many of you all and other folks in our community, in our constituency. And then we basically did our best to write that up as staff and propose it for a research project. And this is something that Wahida and I mostly worked on together, thinking that it could also help to support the work of the regions as they are, as they're thinking about how they can best advocate for services in their areas. So it was very much driven by women living with HIV, bringing these issues to our attention, and then women living with HIV also, kind of trying to turn that into something that we could get resourced to learn more about. Well, I'm seeing a lot of sort of more logistical questions about the confidentiality procedures and stuff, and we can definitely talk about those, but I think they'll be a little more relevant later in our discussion. But what I can assure you is that we're going to hold ourselves to, the highest standards in terms of making sure that there's no data that's identifiable about people that can be tied back to them. And so we'll talk about the exact specifics of that later in the process. And if people have ideas about that too, we want to hear your ideas about it. But what we really want, we haven't even, sort of made a decision about the instruments we're using. So the specific way we might be separating out data and assuring confidentiality will depend on exactly how we do that. Yeah, so there are lots of ways to do it. There, we can create unique identifiers. We will do all of that for sure. So yeah, but we can talk about that again. I think sort of later in the process, we want to really think through what the research questions are with you all here today, and also hear any questions you have about about other pieces of what's been presented so far.
Okay. Hello, Nana. I might have missed something. This is Sharon. I'm trying to determine, so are we going to be providing the participants incentives as well?
Yes. Yes. We will have incentives for you to give to the participants.
Okay. So that would be the requirement of the form that we're going to get them to sign and send off to you all when we send them back to you. Send them back to the data collector.
Yeah, so just to, in terms of how we thought about these interviews, we're going to go through all of that logistical stuff with you on the third webinar, which is going to be on May 15th.
Oh, okay, sorry.
So we'll go through we'll go over all the different forms, all the different processes. We'll say, here's the packet we're mailing to all of you. Here's exactly what's in it. Here's what to do with each part of the thing, and here's what you need to send back to us, and here's an envelope with a stamp on it to do that with. We're going to get that all to you. But what we can't tell you exactly what all the components of that are yet until we figure out exactly what data we're collecting and how.
Okay. All right. Thank you.
Yep. These are really important questions about confidentiality and how we in this project are going to be implementing around confidentiality. I'm going to bring us back to, in some ways, I'm going to take us forward in order for us to kind of step back a little bit and think more broadly about what do we want to learn, okay? So here's this amazing opportunity, this powerful group of researchers around the country, okay? It doesn't happen that often, I just want to add. So what is it that we want to learn, all right? So here you'll see on this slide kind of an overview of what does CBPR look like in action, all right? We've talked about the principles and the history and this and that, and here we are. So, feet on the ground, what does it actually look like? Okay. Well, the first part is, here we are, recruit and train a community research team. And I'm going to bring us to the second part, which is bolded. The research team determines the questions the research or evaluation, so in our case, the research project, will try to answer. So that's where we're going to move forward right now. And then obviously the next step is implementation. So your questions are so important around actually implementation of the research. And then even moving forward after that, preparing reports and recommendations based on the work, on the analysis. Bringing us back to action. This is ultimately about action. We're not just doing research for the sake of it and just because we got all the time in the world and we think it's fun. We're actually wanting to take action to change things. So that's going to come after that point. And then throughout, each researcher reflecting on the learning process and the experience of being part of the CBPR process is really critical. So let's move forward with part 2 here, determining the questions that you want to answer. Okay. So I think these questions were brought up on Saturday's call, but here they are again in terms of the first question really being, what do we think some of the problems and issues facing women with HIV are? 2, given these issues, what do we most want to know about services for women with HIV in our area? And then finally, looks like it's number 1 again, but that's number 3. Are there any changes in funding or service availability to consider locally? Okay. So let's hear that this is really your time to start designing your survey. It really is. What is it that you want to find out? What are some of the primary issues facing women with HIV from your perspective? And let's just start getting a list down. And even if you think it sounds funny or it doesn't, maybe it's not an issue everywhere, it doesn't matter. If it's something that comes to your mind, it's important and we want to hear it. So I'm seeing comments from Pat from the unmet needs. What is their priority?
Pat, can you say more about that? Do you mean from the unmet needs assessments that are done?
I'm seeing you follow up saying on education about HIV services.
Uh-huh.
Okay.
And by the way, we're taking notes on this, on what's coming in on the chat box, and anything that you say verbally as well. Again, it starts with
Hi, can you hear me?
I can hear you. Yep.
Okay, well, basically, we already know from a lot of things that have gone around in South Carolina. We know that housing, transportation, care services for people that women are caring for while they need care for themselves. We already know some of the things, but wanting them to prioritize, what would be the first thing that if they had the opportunity to tackle and find an answer for, what would that be?
So you're talking about asking women to prioritize based on many different kinds of needs, what those needs might be.
What is the top? What is the top thing that they need to make them live the best quality of life?
Okay.
And then the other thing I said was uneducation about HIV services. I mean, it's hard to ask somebody about things that they're not getting or things that they think they should get when they don't know what the services are available to them. Mm-hmm. Because a lot of times people don't know what's here for them unless somebody tells them that knows. Mm-hmm. And it doesn't come from the caseworker, believe me, or the social worker or whoever's in the agency, because they don't even focus on none of that stuff.
Mm-hmm. Great, thank you. I'm seeing here, Heather, you put in the chat box barriers to care /housing. IPV, intimate partner violence, trauma, substance abuse, missing appointments, and medication. Okay. I'm not sure if you're in a place where you can elaborate on that, or if you want to, but if you want to, that would be great.
Basically, I was talking about asking them specific questions as to what are their barriers.
Mm-hmm.
Like, for example, asking the specific questions of, what is your housing situation like? Because obviously we know that these are issues, so we want to kind of get what it looks like for them at that point in time and where the barrier is for because each individual person may have which one of those barriers may be greater than the other, but I think having a list of services that, because we're doing this based on Ryan White, it's a Ryan White research project. So getting a list of what those Ryan White services are and then asking those specific questions of, I'm going to read you a list of services and resources, which one of these things do you need and don't have, or do you need and can't have access to, or, any kind of questions like that. And so some of those things would be listed as, the drug and alcohol abuse treatment, housing, food, dental service. I mean, just like all of them would be listed, and they could say, yes, that's something that I don't have access to, or I'm unable to access for whatever reason. And then we would know more about, okay, if you haven't accessed these things, what are the reasons why you haven't? And then that's when you go into, like, is it transportation, child care, those types of barriers.
I think an important part of what I heard you just say is because this is being done in different geographic areas, having some sense of what are the services that are listed there, and then being able to assess women's knowledge of the services, right?
Yes.
And what they're actually getting from the services then, even if they do have access to them, right? So, great, thank you.
Can you hear me? Nope. They can't.
So I see a comment from Pat Clark also here about providers and provider expertise. Pat, I don't know if you're able to elaborate on that, but we'd love to hear from you as well. Star 6 again to unmute, if you can talk. And then I also see another comment from you, Pat Clark, about both transportation and transportation that's inclusive of child care or being able to transport folks that women might be taking care of, since we know that women have so many family responsibilities.
Hi, Veronica. Can you hear me?
Hi, Veronica. Yes, we can hear you.
I put access to local health care, and one of the reasons I put that is because we have towns where people are going 30, 40, 50 miles just to get care. In one of the areas, like the Barnwell County area, they actually closed the hospital. They don't have a doctor down there. People have to come all the way up to Columbia or other areas that are close by. Well, not close, because none of them are close. We're talking 30, 40, 50 miles one way. So that may definitely be something that is, a detriment to them getting their health care that they need, or getting Ryan White services, period.
And one of the things I think, just to sort of broaden the conversation a little bit, is that even though we're calling this a Ryan White research project, keep in mind that Ryan White is up for complete redesign right now. So, the goal of this project for all of us is to think about coming up with recommendations about what does it really take to, what's it really going to take in this changing environment to improve the quality and access to services for women living with HIV. And we know that that is going to be different in different regions of the country, and we know that there are lots of different levels of resources available, but that there is an opportunity to think about reshaping Ryan White a little bit so that it might wrap around other kinds of services women are getting too. Because Ryan White is a payer of last resort. And so, so what does that really need to look like? Even if a woman is getting her care primarily through Medicaid, for example, what does she still need to get from Ryan White that she might not be getting in Medicaid?
Vicki, can I go on changes in care?
We can hear you if you're trying to talk.
Okay, so one of the things that I think is the issue is the way the Ryan White, when agencies and organizations are granted the Ryan White funding, the way that's translated to the community. Like they take it and some decide to do certain things with it. But there's a lot of times the person making the decision about how to use those funds specifically are not women, and they're definitely not women with HIV. So a lot of times they don't know the specific needs of that community, and if some kind of way they can have some recommendations or they can have some barriers around how they can use it, which I know they do now, but some people are very creative in how they use these funds, and it's not necessarily used to the best ability, to the best to serve the community, the women living with HIV the best. Does that make sense?
Absolutely. I mean, I think you're raising a really important point. Sorry, go ahead.
Oh, I was just going to say, so if once they get this funding, if they can have some recommendations from women living with HIV in different regions, I know the need is different, but sometimes they just for what they want to, fill a gap for, and it's not necessarily for the women, the best interest of the women.
Yeah, and one of the things I'm hearing you raise that it sounds like we might want to consider looking at too is who's making the decisions. How are these decisions being made? Have there been any changes in that over time too? So it looks like we have a bunch of comments coming in on the chat box. Yep. A lot about childcare. If anybody wants to weigh in over the phone, we'd love to hear from you as well. If you want to elaborate on your comments in the chat box, we're getting all your comments in the chat box too. So I see Cindy, I see you're talking about support services for affected family members. I don't know if you want to add anything to that or anything else from the perspective of the Bay Area team.
Right. I just want to also acknowledge, Lauren, your comment, I think, speaks here to what Nana was just talking about the shifting funding context of Ryan White in many ways, the political context here. And, really the underlying root causes are, related to poverty. So I think so many of the things that are coming up in terms of development issues that is absolutely underlying driver.
And I'm also seeing some comments from Vicki Lynn that I just want to make sure we get as well. So a couple of questions about medication access, literally like where are people paying for their medication from? Are they able to pay for it? And then also thinking about how HIV is evolving today. So what are the needs of women with HIV today that might be different, or the desires that might be different than they were, 20, 30 years ago when a lot of these systems were set up? So do women now need employment services, educational services? What is in place?
General education having
HIV. So Deidre, your comment, I just wanted to make sure we say that out loud. Making sure there's general education. Is that what you're saying about having HIV and knowing that just that alone can be a scary battle and lonely?
Yeah, and any of you, if you want to elaborate on your comments, please just go ahead and press *6 and talk to us.
So this is Ebony.
And then yeah, go ahead, Ebony.
I was gonna say that it seems that I know in our area there's a lot of so housing is an issue. It's gonna always be an issue. It's never enough housing. But with the housing that we do have, it seems that there are more housing slots allotted for single people than there are allotted for women with children, which is a huge problem. We can get single individuals housing quickly, but women with children stay on the list for years, and that's a huge barrier to care.
Great. Thank you for raising that. Critically important.
Heather, I'm seeing your comments around, again, kind of the HIV education part, like what actually does a CD4 viral load mean, right? Do women know what this means in terms of other medical issues as well? And a question around, do they feel that their privacy and confidentiality are respected? I'm assuming when you say that, but maybe you could clarify in the context of the services that they're getting. I think.
Yes.
Okay, thanks.
If they are receiving those services from, their providers, do they even know what their providers are telling them? Do they know what their medical if they have other medical conditions, how those can affect those numbers, and what that means? Do they feel that when they're at a provider's location, because I know that we've had, several here in San Diego where the women go there, that, the person at the front desk will be like, say something about them being HIV positive and not even thinking about the other people in the room, or that's, not respecting their privacy and their confidentiality. Just another, what I listed above, which is lack of trauma-informed care from providers. I feel like there needs to be a lot of training with not just, the people in the HIV community, but providers in general, doctors, people that are going to be working in those medical environments, that should be something that is required, trauma-informed training.
Great point. Let's scroll up and see if we missed anything up there. So I'm seeing also some questions about immigration, undocumented women, wanting to know, maybe like wanting to know what the state of services and availability is and what the need is for undocumented women in particular areas, because Ryan White is the only payer really for women who are immigrants. And then some questions about stigma, distrust of the medical system, that I think might also relate to the questions about privacy and confidentiality that also came up. And then wanting to know sort of about the quality of services. So if they're receiving services, how helpful are these services to them? Are they really working? So these are all really great themes that we want to make sure we figure out how to incorporate. And then I see Lauren, another specific concern about older women, which we know is an emerging aspect of the epidemic. So older women with co-occurring conditions, are they getting the complex care that they need, or, are they just getting care for HIV, or are they just getting care for diabetes or whatever else is going on? Are these things really being treated together and addressed together? Also some questions about medical coverage. What is it covering? What is it lacking? Legal issues, really important questions. Thank you all for raising these. Does anybody want to jump in with additional comments? *6 again. And then I think soon we want to ask you the last question on this side, a little more specifically. Now that I think we've gotten like a pretty good list. And one of the things, the family of women living with HIV. Yeah, thank you, Cindy, for raising that. So the family of women living with HIV, affected community members. Mm-hmm. Cindy, I don't know if you want to expand on that at all verbally, or if you're in a place where you can do that. But if you are, we'd love to hear from you. *6. If you could talk a little bit more about what you think some of the issues are and what some of the needs are. Okay. We'll look for you to type in on the chat box.
So this is Ebony. I actually do have a family living with HIV. We've had specific issues where a mother has either went into respite care or unfortunately passed away, and she had teenage children, and then there was just absolutely no support for them. And if they're like 18 or 19, they're not really old enough to.
Great. Thanks, Ebony. Cindy, we see your comments on the chat box too, so thanks for weighing in with that. That's really helpful for just fleshing it out a little bit more. And we'll definitely circle back on some of these issues again in our next conversation. I'm also seeing mental health support, what's in place for the family. And then Pat Clark is giving us a list of the Part D services that are funded so that we might have some direction around how we want to guide our questions. And it seems like there's a lot of concern about family members. So that's helpful to hear. I see your comments, Lauren, as well. Whose family? How is family defined? And then how transportation is provided to folks that might come along with the woman. Women don't come alone usually to anything. We're always rolling with like 4 other people we're like, carrying. So these are really great. And so let me ask specifically, in all of your areas, are there any particular changes in funding or service availability that you've noticed over the last couple of years that you've heard about? You're all involved in your communities, whether it's at a planning council level or providing services or as advocates. What are the changes you're seeing that we should be thinking about as we take this project on? We want to hear from you about what you're seeing on the ground. I see funding for peer support is being cut, so that might be something we really need to look at. Funding for peer services. What else are we seeing on the ground?
HRSA narrowing down scope of what funds can be used for, Pat, seeing that. Mental health is being cut. Women-centered services is being cut or lacking in general.
And can we ask for any specific examples of what kinds of cuts you're seeing? Are they at a community-based organization level? Are they at the whole planning council level, the planning council is reallocating funding? Are they other state funds designated that are not HIV specific maybe, but that are affecting the services available to people with HIV? What are some examples of the cuts you all are seeing?
This is Heather Christie, from San Diego. My only real true example that I can give you is that I was working at Christie's Place as a retention and care peer navigator, and I think we were funded by AIDS United for those services, and Ryan White, and I believe AIDS United stopped funding for the peer support services. And then right now I know they are asking for funding through the planning council and things, but because and the issue is that we don't have women that go to those planning council meetings. We lack the women empowerment, I guess you could say, here in San Diego, where women don't go to those planning council meetings, and so our voices don't get heard. And so we are the first for the money to get allocated in other areas as opposed to, towards women's services. So I think that that's a huge, one of the huge reasons why the funding is lacking for women-centered services and for the peer support, because in the male community, all of the pretty much males that work there are peers in those places, whereas there's not that many women peer supports or services around, and it's because we don't have women speaking up and saying that these are needs because they don't go to those meetings.
Great. So thank you for that. I'm also seeing from Florida, from the Tampa area, that legal services is being cut. And we're seeing that, there's some cuts in Michigan to Ryan White funding for psychosocial support groups, and mental health services. And then from the Bay Area, we're hearing that there have been some cuts to funding for food for community advisory board meetings under Ryan White Part D, which we know can impact what Heather was just talking about in terms of involvement of people with HIV. And then I'm seeing from Vicki Lynn here that there's a change in who's administering the contract for ADAP, and that might be resulting in some changes, or it might be something that we need to look at in terms of how it results in changes to who's eligible for ADAP in Florida. So lots of changes happening at the state level. And Ebony, I saw your comment earlier about cuts to funding overall for women and children at the state level, which is, I think part of a trend we're seeing all around the country, really, and the recent cuts even to SNAP and the food stamp program or Supplemental Nutrition Assistance Program, which is, not something we traditionally think of as HIV funding, but we know that it's something that impacts a lot of the folks we work with and represent. Seeing a bunch more comments. So some questions about wanting to look at what's happening even within Part D with the targeting. So Part D has historically included youth as well. Are there shifts to how Part D funding itself is being used within Part D? And then how are the qualifications or criteria for who gets services changing towards this medically severe issue or medically frail issue that, Lauren, that you're raising? So the Planning Council did not make these changes. This is coming from the federal government, who's retraining providers. So that's really interesting. And it would be really interesting if we could find a way to document that. We'd love to, I don't know, Lauren, I know you can't talk, but if you have ideas about ways that, where that kind of stuff is being documented, that would be helpful to know. And then here, Pat, I see your comment also that the Michigan Department of, I don't know if that's community health or what that is actually, had been talking about removing the women part. I'm guessing you mean the women part of Ryan White and focusing on MSM, age 24 and younger. So again, if we can find places to document this, if it's in like a transcript or public comment from a planning council meeting, that will be very helpful. These are all aspects of data collection that we might not have thought about before, that are, I think, surfacing from some of the questions you're raising. Is like these conversations are happening, even if some of them haven't become action yet, there are still these conversations happening, and we might want to have a way of trying to track some of these conversations.
Right. So part of the data collection might be through surveys, but part of it might also be you actually, being able to identify what is happening specifically in meeting notes or whatever. Right?
Yeah. Okay. Great. These are all really good. Thanks, Lauren. Yeah, thanks, everybody. Is there anything else that folks want to say before we move on from this question to a couple of other questions around trends, changes we might want to look at?
These are all really, really important, critical issues that we'll want to be figuring out how to assess again specifically in your specific areas through the survey. Mm-hmm. Any final thoughts on these? And these are kind of the big picture questions. And then on the next call next week that we have, I think is it Wednesday? We're going to have an opportunity to get much more concrete about how to even ask questions on a survey to find out more information about these important topics. Okay. For now, I'm going to move us into a couple of questions that relate to the methods, that relate to, as you've already raised, the important issues around how we actually do the research itself. Okay. So the first question that I think came up on the Saturday call that you were asked to think about is recruitment. Where will we recruit women with HIV to participate in a survey? The second question has to do with key stakeholders. Who are some of the key stakeholders, the most important people we might talk to, either individuals or organizations? So go ahead and unmute your call to talk or post to the chat. Because who we do the research with, who we talk to, and how we find people are absolutely key for the success of our research project. Mm-hmm. Here, Pat Kelly, I'm seeing women's support groups, women's HIV organizational groups, and AIDS service organizations. Great, Pat Clark, recruitment in Michigan. Okay, partnering with the community liaison at Gilead to do outreach. Great, so partnering with...
That's a good idea.
That's a great idea. So partnering with other, kind of current outreach work that you're currently involved in, I think is a really good idea. Veronica, we have ASO case managers, so letting case managers at organizations know about this. Oftentimes case managers will be the first people to be able to identify some people. Oh, what are the ages that will be targeted? Is it over 18?
Yeah, I think, Christina, your question about the age range is really good, and to some extent, we might need to define it after we figure out exactly what we want to know. But I think that for practical and logistical and just sort of ethical reasons, we know that it'll be adults. It'll be adult women, so women who are 18 or older who can consent for themselves, because we won't have a process in place to manage, like a custodian or a parent or somebody consenting for them. So it'll be 18 plus, but even within that, we might choose to say, based on the questions we have, we might choose to say we want we want to get like X% women in our sample who are of a particular age, like reproductive years, X% who are like above reproductive age, so that we can figure out what's really going on in these different groups. Or we might not. But I think it's a really good question that we are going to need to figure out together. Mm-hmm.
Cindy, I'm seeing, the clinic where you receive care, Open Hand, so food pantries, clinics, former participants in trainings. So it sounds like people who you may have worked with, people in your networks. I'm sure each of you know so many people and have really extensive networks, and the power of networks and our own relationships are not to be underestimated in terms of really recruitment. Mm-hmm. Meta, you're talking about in Baton Rouge, recruiting women from hospital, clinic, health center, heart, VOA, family services, okay, local docs. Great, it sounds like there are many organizations there who you're planning to partner with.
Yeah, I think, one of the questions we might need to figure out at some point before we start recruitment is, who are we really trying to find this information about? So, depending on what our exact questions are, there's like a set of questions we could ask about, like if we were only talking to women who are in existing Part D programs, that would look really different from if we were talking to women who are receiving Ryan White services, period, any kind, and some of whom are in areas that are served by Part D and some that aren't. And then all of that is separate from if we said, we want to somehow track women who are enrolled in Medicaid or who are like getting Medicaid and compare them with women who don't have access to Medicaid. So there, I think our exact decisions around recruitment might emerge more clearly once we figure out exactly what our questions are. But any sort of intel that you all have around that, if you know who some of the, if you know in your particular areas, we know that there aren't Part D programs in all of your areas because we've done a little bit of a scan of that. So we know that we don't want to just limit it to Part D, women who are receiving Part D services. But I think one thing we don't know is how many of the women that you all are working with are getting Medicaid. And that might be something that would be helpful for us to, if you have any sense about that, that would be helpful to know. Or if you know that in your area it's really hard for women to get Medicaid because there's no Medicaid expansion, for example, it's helpful for us to think about that too. And then there are questions about, how to either prioritize participation of or find a way to reach out specifically to women from particular populations or who might have particular needs for services. So, for example, women who are recently released. That's a good point.
Yeah.
So, Part D, Part D. Oh, Pat.
And I saw a question related to, so Vicki, your question, can we recruit from clinics without an IRB? Some of the clinics would not allow this without approval from IRB, and that's going to be something to be aware of because there may be some environments where that might involve, going through an institutional IRB. So I think we're going to have to find that out based on the specific clinic environment. But in terms of, recruiting at more community sites, that's okay. So I think that'll be something to really look into on a bit of a case-by-case basis.
And Ebony, I know that last time when we did the Sexual and Reproductive Health Project, I remember that you were one of the community-based researchers and did some of the outreach. I don't know if you have any tips from that you think it would be helpful to share with this group about recruitment. Ebony might not be in a good place where she can talk right now. But this is really good. It sounds like we have a great potential list, and even if we can't recruit at clinics because of the IRB constraints, you all have so many connections in your communities. It's really clear that we'll be able to do it. Oh, sorry, Ebony. We couldn't hear you, so if you want to try *6 to unmute yourself again, we could try to hear from you again. Oh,
Okay, yeah, we still can't hear you. maybe type in any other thoughts you have for now.
Yeah, and we can, again, we can revisit this question again on another webinar. So, and we'd love to hear from you with more ideas about that later.
Mm-hmm. Great, lots of great ideas. It's clear that you're very connected, and again, asking people to fill out a survey in a clinic, in a hospital environment, for example, if you have permission of the clinic director to do that is okay, with a clear understanding that it's not a project of that institution. So, I think there still are possibilities for clinical kinds of recruitment as well. Interviewing people who've been recently re-engaged in care to find out why they dropped out of care, Lauren. I'm seeing your comment here. Okay. Yeah, and oftentimes you can do, Pat Clark, what you're saying, in a clinical setting, you can pass on a link to a survey, for example. So,
or you might be able to put up a flyer,
right,
and say, come have lunch and take a survey on Wednesday at this other place.
That's right. Yeah. Okay.
Hey, this is Ebony. Can you guys hear me?
Yeah, we can hear you.
Okay. So when we did the reproductive survey, most of our participants, we did do in the hospital, and they do have their own IRB process, but because this is not one of their research projects, they didn't require us to go through anything. It was just a point of coming in and asking the women in the groups in the different clinics if they would be interested in doing a survey, and they said yes, and it was fine. But because it's not their research project, they don't require you to go through anything. It's fine if the women consent, they're willing to do it. And that's most of the recruitment we did like that through advertising with case managers or clinics, housing projects that housed women who were positive. And it was we had a computer model too, so we were able to send out emails and things like that to women that we knew used the computer. So that's pretty much how we did most of the recruitment.
Yeah.
Great.
That's really helpful.
Yes, that is helpful. And I think, it's important to clarify that it's not a research project of that institution, so it doesn't have to go through their IRB. I think the key is always, though, making sure that people know, program managers or clinic directors know what you're doing, obviously, right? Before going in.
Common, I think.
They would, right, exactly. Getting the buy-in. Your comment, Pat Clark, is exactly what I'm saying here. It's so important to get the buy-in, right? Great.
And I would say getting buy-in, it was better when I just explained to them in a broad sense what I was doing and not in detail, because when I did it in detail, once somebody got suspicious, like we were trying to find out if they were doing right or wrong. And so when I started explaining it just in a broad sense, everybody was okay with it.
Yeah. Yeah, thanks for clarifying that. And I think we'll definitely be looking to you all to share sort of like tips and lessons learned along the way as we keep doing this.
Absolutely. And I think, one thing that might be a good idea is to kind of come up with a one-pager or kind of a brief overview, so that you can give that information out to people. Just kind of, this is what the project is and what we're doing to use in these kinds of recruitment situations.
Yeah. So these are all really good suggestions. Thank you so much. I see a couple other, I see, Lauren, your request for an introductory letter. I think that's exactly pretty much what Sonia's talking about with a one-pager. So we'll have something that you can use so that the language is standard and they know where they can go for more information and things like that. And then I see another suggestion about pharma reps, connecting with pharma reps as an outreach strategy again, which is a great idea. So, we're at about quarter of almost. So I think we want to transition into talking about some next steps and thank you all for your really thoughtful comments. That's been very helpful. And what we're going to do with the input we got today is we're going to be trying to sort of like theme it into some topics and think through those with you all on next Wednesday when we do the conversation that goes more in depth around how do we generate questions, how do we generate like research questions, survey questions, how do we really think about doing that, what's doable, you know, because we might not be able to do everything in this project. We might have to prioritize some of these pieces over the others, and we want to do that together as a collective process. And then really thinking about, you all have raised some great points today, so I just want to encourage folks, you know, over the weekend and over the next few days to think about some of these questions around other sources of data besides surveys, because we're definitely going to, it sounds like we definitely want to use a survey tool of some kind because we want to talk to women with HIV directly about their experiences. That's no surprise, that's what we do. But it sounds like there are other kinds of data we want to gather that might be more around what's happening in the ether, like around like what are the current conversations about funding for women, what are the current conversations about the types of priorities that are being defined and decisions that are being made, and even if stuff isn't showing up exactly in the documents yet, like how the healthcare department is prioritizing or how the planning council is prioritizing, what are sort of these like discourses that are happening right under the surface that we want to try to document in this process. So, you know, thinking just like sort of creatively and out of the box about that, like the stuff that you all brought up about, well, this happened at this meeting or this happened in this committee, that's data, and we should think about how to best collect that too. So give that some thought over the next few days. I think Sonia is gonna share a few resources with us before we kind of move into the practical next steps between now and Wednesday.
What an amazing series and source of, you know, topics you all just raised. So there's so much here to capture. And I do want to echo, you know, Nana, what you just said about really thinking outside the box and thinking creatively. So you are, each of you, moving forward as researchers. You are setting out to discover and find out things. You've just identified so many important, you know, very broad, kind of big picture issues and topics. So the next part of the work now, moving forward with the research project, is to get really, really, you know, kind of concrete and specific about how, you know, not just kind of then what do we ask about, but how do we even ask about it. So we will talk about that more next week, but I'm going to ask you, you know, again, just sort of seconding Nana's, like, think outside the box, think creatively, but I'm also going to ask you to think very concretely and specifically. Like, if there were 3 things you wanted to ask women living with HIV through the survey, this is your survey, okay? You are making the survey, you're going into the field, you're going to be administering the survey and finding something out, and it's an amazing feeling to, when you are, you know, everybody who's participated in doing research before as researchers, it's so powerful to see, wow, this is a question that I had and I'm really interested and invested in finding more about, and then you see the answers coming in. So think, you know, if there are 3 questions that you would like to ask women with HIV, be thinking about that over the weekend, and then we can kind of bring that to our call and conversation as we get very specific next Wednesday. I'm leaving you all with a slide on resources about community-based participatory research for you guys to just, you know, you can click on the links here, provide more information about CBPR. If you have questions or anything, please, you know, just let me know. I put my contact info on the end. The final slide here, my email, phone number. Always feel free to be in touch with me if you have questions that come up. And now I think we're going to move into next steps, but I, for one, am really looking forward to our conversation next Wednesday. So I'll look forward to talking more then. I'm passing it back to Nana.
And I'm going to actually pass it to Narissa, but before I do that, I'm going to just quickly say that, you know, so I think a great next step that's not on this slide is what the challenge that Sonia just put out for us. So if you can connect with your partner over the next few days, over the phone or, you know, whatever, and think about, for your team, what are the 3 things you most want to know? And it doesn't need to be a perfectly formulated question. Don't worry about the wordsmithing of it. But if you had to prioritize for your particular geographic area, what are the 3 things you most want to ask women living with HIV? And if every team comes with 3 things, then we'll have at the most 21, and maybe some of them will, it's likely that some of them will cross over each other. That'll be a really great place for us to start in terms of actually designing this tool that we're going to be using. So I'm going to go ahead and turn it over to Narissa to close us out, and thank you all so much for being with us late on a Friday. I know it's really late on the East Coast.
Hey, everybody. So just a couple next steps. I know y'all have been hearing from me a lot lately with emails. So I've received contact info from some of you, phone and email. Please send that to me when you get a chance. I created that Google group so we can stay in touch with each other that way. So please accept the invitation. And then make sure you mark your calendars for next Wednesday, the 29th at 3 p.m. Pacific time, 6 p.m. Eastern, 5 p.m. Central time for our Michigan, right, and Illinois folks. And then on May 15th at 3 p.m. Pacific, 6 p.m. Eastern, we will have our final webinar where we'll just talk about project implementation and those logistics. So some of the stuff that came up today, please save that, and then we'll talk about that in that last webinar. So your homework, 3 things you most want to know about women, you most want to ask women living with HIV in your area. Save those, and I'm going to ask you to email me once you've talked to your team member about that. So, and then what I can do is I can post in the Google group and everybody can see everyone's responses once I get everyone's response. And we can see how that works out for the Google group that first time. This is recording, so you all will get a copy of a link to this and then a link to the slides as well for your review at any time that you want.
Are there any questions, if we do have a couple minutes before the hour? Any final questions that you all have or final thoughts that you want to share? Yeah, we agree, Pat. Okay.
Have a good weekend, everybody.
Yeah, have a great weekend, everyone. Thanks again for everything, and a huge thanks to Sonia for time with us. Thank you.
Thanks, everyone. Talk to you next week.
Have a great weekend. Bye.